I am. Yeah, I'm just kidding. I'm going at you. It's. But and then you go out stroke to the yeah, it's like so they go out and slept with comes and go out and patio. Okay. Just like when you find it, them up. Always come here. There's I usually get it by now. I've got it. Yesterday. Oh no. So you need like that magic fire for each other. Yeah. Which I guess makes sense. Yeah. There's a lot of places to get I know it's possible. I don't sell So I'm having over here. It's not fair. It's fine. But it's trying to show and all they do is like and I'm like right now. I just want to you're trying to get at what yeah, and I can show. This is the agenda. It's like exactly. I didn't grow up because right out. Really? True legs. I don't have my I was thinking of sometimes you could be it's a long day and then other days like endurance days short but like I remember if you would practice yeah and I remember like it's all like knocked down and house now and everybody He's like march around here, there's all the ones around. I just feel that's a journey. I don't know if it's back and it's the trans back there and stuff. No, it's like, it's all one line. It's just so bad.
No, wait for the break. Yeah.
And I was the captain.
Every test is on like
I wasn't hesitant, so I didn't want to make it. Yeah, I was hesitant, so I was like.
She really thought it there.
Yeah. I didn't see it. What was the water? I mean, just put it down and then just.
That's right, he's gonna carry it. Long to hold the stuff.
It looks like it's one here. Yeah. Or the. Oh my God, oh, and I just take care of it. There we go. Oh, I look like the guy. Well, so many memories of these dropping. Yeah, I like lots of things. I'm like, wow, they all should see there. So, I'm thinking to just here's the microphone and everything I need. So I particularly driving down here, you guys are very, they can talk about it. Yeah. I know. But no. And plus, you know, Let's not do this stuff again. Oh, I did. No, it's still doing that. Yeah, fertility. And I went in, basic, and that had already done like the whatever. Yeah, we did that for like. We did something else, and then Eric. And that's my friend. And then when I came it up, yeah, I was like, I never got. Yeah. And then and everybody said, yeah, you never know.
I see everything's come back.
Yeah. Right.
Well, that's good.
Yeah. I do think brother-in-law can understand these things. Naturally. She told the doctor, she said, Absolutely. She got research.
And then, so sorry, if I had a book, I think it's 6:30. Just trying to find it, because I haven't actually been in here. No, I have no right here. Yeah. Oh, yes.
Yeah, I should. Yeah. Right. Oh, no, I'm not saying.
Gotta tell. That's terrible.
Thank you. Take it easy.
Insurance, right?
Give you a hug. Thank you for being here. Hugs. Thanks for being here.
Sorry.
I get a book.
Some of that.
Yeah.
Just today. Every day. It's a strike, yeah. You can strike more dinner if you like. Better.
Thank you.
I told you I'd give him the time.
Yeah.
Innovation Conference, welcome. We're really excited to have you all here today and for the rest of the week as we talk about all things stroke, brain aneurysm, AVM, and all of the other cerebrovascular conditions. Like I said, we're really excited that you're here. I think this is the ninth innovations. So a long running tradition here at Baptist Health, and we're really proud to bring awesome speakers to you guys and give you a week of excellent continuing education. So I have a couple of announcements. I'm Wendy Camp. For those of you who don't know me, I'm the stroke program director here at Baptist Health. I'm also the chest pain program director. We've got a lot of really awesome stuff happening at Baptist right now. So stay tuned for more from that side of the house at some point. But today we're gonna hang on a second. Oh, Wi-Fi. I forgot. Hang on, let me go back. If you guys need Wi-Fi for any reason, it is the One Ocean events. There should be no password. So if you have issues with that, please let me or Chris know. If you guys have any issues with anything technology-wise, like I said, Chris can help you or I can help you too. Schedule. So this is pretty typical for us. Today is Nursing and Allied Health Day. Tomorrow we have brain aneurysm, and then Friday we have stroke day. So we're covering ischemic and hemorrhagic stroke on Friday. So attend as much as you can. We'd love to see you all here for the rest of the week. Continuing education announcements. So there are QR codes on your tables for both continuing medical education credits and continuing education units for nursing. If you are an RRT, we can also help you with that, so just see us and we'll get you instructions on how to claim those CE credits. Susanna Tedrick, our awesome stroke program educator, can help you with this, as well as the stroke coordinators who are usually out at check-in. So if you need, if you need anything, see one of us. And that concludes like the brief housekeeping announcement. There probably will be a few scheduling changes a little bit later today. We did have one speaker that was unable to join us because of illness. So we're sad to miss him, but you'll see some schedule changes primarily after lunch, but there will be a little flip this morning. So just stay tuned. So I'm going to introduce Dr. Hamill and Dr. Nima. Dr. Nima is our stroke program director, medical director here at Baptist Health. Dr. Hamill is the chair for the Neuroscience Institute here at Baptist Health. So I'm going to let them say a few words to you all before we get started.
Morning, all right, great crowd. Looking forward, very excited about this conference. As you know, we do this on a yearly basis. Thank you, Wendy. A lot of work goes into this conference, so you'll see we have a great line of topics and great speakers. But most of all, I want to thank each one of you in here. Everybody knows, the work that we do is not easy, and we can never do what we do without you guys. So I just want to say thank you, and looking forward to seeing everybody today, tomorrow, and Friday. Dr. Hammond.
Thank you, Dr. Nima. I cannot do a good French accent, but I would impersonate Eric Sauvageau. Somebody has to be in the hospital. Thank you everybody for being here. This is very dear to my heart, to our hearts, because for me this is a celebration of our team. It does take a village to do what we do. I think we can be very proud that we do phenomenal. Was afloat. It's not easy to organize all this with all the politics and price hikes and all this. Support of our industry partners and actually Baptist where we are. I don't know how long we start doing this, that the big standing here is super cool, and I'll say that enough. Silas Turner, Sydney Turner, Sydney representing mom and dad that are super cool people, educators at heart, that I think that's what we are with our patients. We treat patients, but we also educate stroke prevention, stroke treatment, go all over the world teaching that. I really appreciate your willingness to open your chest and show your wounds, because that's inspiring, that's a healing. So you guys are going to see what I'm talking about. I don't want to steal the thunder. I said this about Sauvageau before. I said this about Nima before. I take a 2% credit because I attract Eric to Jacksonville and we attract Nima to Jacksonville. And the same applied to this younger gentleman sitting here on my left. Dr. Daniel Ikeda is our quote-unquote junior partner. Daniel trained at the Ohio State University. I know he's going to learn to be a Gator a little bit. He's in Florida for crying out loud. So Danny was a resident with Eric when Eric was at the Ohio State. And Danny trained with another Daniel Privedel, that was my junior resident, a guy bigger than life. So Dr. Ikeda was partnered with Dr. Shaw. They were co-residents. So they lived 7 years together. And Shaw ended up with us as a spine surgeon. and Daniel was serving, our country, paying back his dues. And during his time, there, started doing, locals with us. And as a great relationship that came to fruition, that we started a relationship with Dr. Ikeda coming once a month to help us. And we need a new partner, and we had the joy of landing Dr. Ikeda here with his beautiful family. In one of these, I think you're still local, so we did, you did this phenomenal work. This kid came with a massive brain bleed, and Dr. Ikeda was on call, and we do see a lot of complex cases, and thankfully, we had a very well-trained neurosurgeon with a big heart to help this guy here. Dr. Ikeda, please come up. And you're gonna hear from Dr. Ikeda. Did I break the protocol? Is that the opposite? This is Danny first, right? It would not be the first or last time that I'm wrong in my life.
You just get looked up here. Great, so for those that, there's a lot of familiar faces here. Those of you that don't know me, my name is Dan Cada. You know, I got too generous of a introduction from my senior partner, Dr. Hamill. But you know, I have you know, they always make us do these slide disclosures. I had none, other than maybe I wish I had some. But, it's true, I just started here in July, and before that I was in the military, and I couldn't ask to be in a better place here with partners like Dr. Heidi Green, you know, Dr. Gannell, and Dr. Sotojo. And just I think of, you know, when I was in the military and then looking for jobs, and I had a few different options. I think, you know, there was no program like the one they had built in the Baptist. And so, you know, I got to really kind of ride on the backs of giants or people that had come before me and kind of, you know, just come right in and work with such a great team. And so, really, I just feel have a lot of gratitude when I think about my current position and the partners that I have, the system that I get to practice in, the patients that I get to take care of. So I thank you. You know, I'm charged with talking about AVMs this morning, and I think that's our guest of honor too. We'll talk about it in a little bit. And I know a lot of you have a lot of information on this topic. So some of this might be a review, and then for some of you, you know, it might be kind of a good introduction to some of the stuff we talk about and the nomenclature we talk about when we're talking about AVMs, because sometimes it is confusing. You know, just to kind of get back to regular human physiology, when I think of AVMs or arterial malformations of the brain, I think of a disruption of normal human physiology. I think, you know, we all think about the cardiovascular system, we think of big wall arteries, which carry blood from the heart, and then deliver nutrients and oxygen and sugar to parts of our bodies. And then they do this through this big capillary bed. These arteries are high pressure, low volume, and then there's this exchange of stuff in the tissues and organs, and then the blood gets carried back to the heart in this kind of higher capacity, low pressure, high volume system called the venous system. And it's really important that there's this intermediary we call the capillary bed, which kind of dissipates that pressure. And AVMs kind of disrupt that. So these are, especially when we're talking about vascular, these AVMs, because there's lots of vascular malformations in the brain, you guys have heard of aneurysms, cavernous malformations, maybe venous angiomas or capillary telangiectasias. AVMs are a specific type of vascular malformation that are thought to be congenital or you're born with, where there's this interweaving, where there's this nidus, or this cluster of abnormal blood vessels, which kind of takes away that capillary system and puts pressure on a venous system. That's the way I think of it. So this kind of cartoon shows that with, you can see this internal carotid artery coming here, and these are the middle cerebral arteries here, and this is the anterior cerebral artery. It's all contributing to this conical shaped nidus. And then these structures here on the side should be blue, or these venous structures with low pressure. But because there's this nidus here, it puts pressure on the whole system. And so, you're born with this, about 1,000 people are born with something like this. And for most days, most years of your life, it never causes a problem. But sometimes they can cause symptoms. And then when I think about symptoms, I think about them, is it symptoms related to hemorrhage, or is it symptoms related to irritation of the brain, or is it incidental? We're finding more and more of these incidentally, because if you have a sinus headache or if you have a mild TBI, we'll go to the ER, then you'll get a pretty, what was before, a pretty advanced study in CT scan. Now everybody can get them very quickly. Even standalone urgent care centers, when they have such imaging studies, we need to find them incidentally. But other times they cause symptoms by hemorrhage, of course. Those are usually more urgent. They can be mild. They can be like mild headache. People confuse it for a sinus headache. Or it could be something severe like coma or lethargy. And then there's rare cases where they cause symptoms without hemorrhage, where they could steal blood away from the other side of the brain and cause ischemia or irritated through seizure. So, I already kind of led with it, but we talk about making these diagnoses. You can see here, this is a patient who had, I believe this was a young lady, she was pregnant, we were taking care of, and she came in with a seizure and very sick. You can see this very obvious large hemorrhage here. And, obviously this is normal for a 24-year-old or a 25-year-old. And so, we investigated them with another type of screening study called a CT angiogram. So you go from a plain head CT to a CT angiogram. You can see here, this study kind of de-emphasizes the hemorrhage, which is right here. And then the contrast kind of evaluates better the blood vessels. And here you can see this kind of cluster of blood vessels here. But you can see in this picture how the hemorrhage is not as bright as is it here. And here's another one where we call, it's almost strictly intraventricular hemorrhage, where the blood is kind of in the fluid-filled spaces of the brain called ventricles, where spinal fluid is made. And again, here's this CT angiogram, which shows this kind of nice conical cluster of blood vessels here. For people that can be evaluated electively or in these non-emergent settings, where they have time, you could get an MRI. They really show kind of the detail of the location of the brain and can kind of show how structurally it's related to more adjacent critical areas of the brain, a little bit better than CT scan. And you can see in these few studies, these blood vessels appear very dark here, all these flow voids. And then here's a patient here who had a seizure. You can see this kind of white, light, fluffy stuff around these flow voids, which isn't there. It's not hemorrhage, that's cerebral edema or swelling. This patient presented with a seizure. So likely something happened, they had a micro seizure, or there was more pressure on that nidus, causing this irritation, and the patient had a seizure without hemorrhage. MR angiograms are similarly okay, and probably not as good as CT angiograms, but they can show this kind of large cluster of blood vessels. And then really kind of define this AVM is these old standard studies, which we do here, called diagnostic cerebral angiograms, which we hear let's talk about them quite frequently if you work with us. And here's a two-picture slide where you can see this is what we call an AP, and then this one over here is a lateral of the same picture where you see the catheters proximal to this here in this area, and they're injecting the contrast with these kind of very detailed x-rays or these very fast rate x-rays, very clear pictures, and then the patient holding still, and you can see this kind of going up here. And then this is an internal carotid artery here, going up to this blood vessel here, which is the middle cerebral artery, and there's the anterior cerebral artery. You can see how much blood flow is going here. This is almost strictly a fed by the middle cerebral artery. And then here you can see this is that major problem we're talking about, is this draining vein here. And so I was teaching residents before, I would say, you know, if you see artery and a vein in the same picture, it's almost always a problem if you've done it right. There should not be contrast in both an artery and a vein in the same time. It should flow naturally through the arteries to the capillary bed, and then you should have that venous drainage. So this is a concern, and this is really diagnostic of AVM. Here's a few slides I added, but I'll run through these quickly just in the nature of time. You know, if somebody came in with a hemorrhage, the decision making for all this is pretty easy, right? We evaluate them, take care of their ABCs, treat their intracranial pressure, talk about surgical ways we're going to treat them, recover them as best we can. But the real question is, what happens if somebody came in and they don't have that, right? What if your 80-year-old grandfather had, fell and struck his head and then goes to go get a head CT in urgent care, and now he's got this AVM? Does that mean we need to treat him right away? I guess the answer is it depends, you know. And in 1983, and then in 2001, we didn't know it was probably 2 to 4% risk of hemorrhage per year. These things we try to study all the time, and we never really got a good handle on what's the really needed, but we still think it's probably somewhere between 2 to 4% risk of bleeding per year. And depending on the size, structures, and then other intrinsic factors related to the anatomy of the AVM, depends on whether or not we should treat it. This is something I found, it's kind of very progressive. My research, I remember this study a while ago, was 1974, if you were a young woman who were found to have an AVM, their recommendation was to deliver the baby by C-section and then do a hysterectomy at the same time, because they said the likelihood of having a hemorrhage in the future was so high as 85%, and that they didn't have good measures to treat the AVM, so they figured pregnancy was the biggest reason for them to cause bleeding. So they would sterilize these women. Obviously, it wasn't funny, but that was state of the art in 1974, which I don't think is a typical recommendation we have nowadays. Even in our best studies, you may hear, if you're at different centers, some controversy in the past 10 or so years about whether or not we should treat AVMs, and that was done by this Aruba study, which was had multiple kind of methodological flaws, I would say, which really made it not easy to glean anything from, and it is quite highly controversial, I guess, to say that we could draw any major conclusions about whether or not we should treat AVMs electively. But it did show one thing, is that they had about a 3% rate of hemorrhage for all their patients. So I think that 2 to 4% risk that was around in the 60s, 70s, and 80s is probably true. So let's say we get to the point where we talk about treatment. What are your options? I think most of you are probably familiar with this view. You see us in the OR, and this is probably a typical view of somebody doing microsurgery. This was kind of the gold standard, I think, 30 years ago. And sometimes today still is the best. When I was in Okinawa, there was a young woman who presented, and we didn't have a biplane suite, we didn't have radiosurgery. And during the lockdown, I did not have the ability to transfer the patient to University Center. And this was another young lady, I think she was 27. She has, what they said, sinus headache for a week, and then kept coming back to the emergency room. And they thought maybe she was drug seeking, and then she collapsed outside the emergency room and had a seizure. And then, they got a head CT, obviously there's this large hemorrhage here, we got a CT angiogram here. This is a, very, we grade these AVMs 1 to 5 in terms of their surgical difficulty. I think this would be a grade 2 at the worst. I think this is a kind of a lower grade AVM. So she was a good candidate for microsurgical resection. You can see this kind of, it's not a great picture, but you can see this is the surface of the brain here. This is the covering of the brain called the dura, or the cervical patty. And then you can see this very bright blood vessel here. This is the draining vein here that's coming from that. And this is where the hemorrhage was coming from. We were able to resect that and remove it entirely. And then we did a medic CCAT flight to Walter Reed a couple days later, and she did great. Although I never followed up with her. But here's, and you can see the hematoma is gone, and here the AVM is also gone. I think one of the biggest advancements we've had from the surgical standpoint is try to minimize the amount of kind of large surgeries that we offer people, especially for complex AVMs, and that comes in endovascular therapy. And I think a lot of you know that's when we kind of gain access to the AVM through a femoral artery or a radial artery, and then we take a series of long catheters, could be the caliber of a stirring straw, could be the caliber of a McDonald's straw, something like that. And then we get into those blood vessels, and then we can put what we call embolic agents. And those things vary from gel foam to very expensive titanium or platinum foils, or now we're doing things called onyx embolization, where it's almost like a lava. And can be placed inside the blood vessel, and many times now, actually, higher safety than surgery sometimes. And so here's kind of another cartoon of they're injecting, this looks like onyx into the AVM. And wish I had a video of that, but here's a picture which I think that illustrates it really well. Here's a very similar to that prior AVM that I showed, with almost 100% contribution to the middle cervical artery. And this was an older gentleman who had bled, I think he was in his 80s. The bleed wasn't very large, but he had a seizure, and I talked to the family, and this was at Walter Reed. He said, if we're going to do something, we should try to do it on minimally invasive as much as we can, because he was a very fragile gentleman. And we were able to embolize the entire AVM through the blood vessels. That we're not always able to do that, but in this case, it worked out really well. And then the third treatment you may hear or recommend to patients is radiosurgery, where we deliver multiple cannulas or multiple areas of X-ray, basically, or gamma ray into somebody's AVM, and high dose radiation, which would kind of cause hyperplasia with an AVM and cause it to kind of embolize itself or thrombose itself over a long period of time, usually 1 to 3 years. So it's not a great procedure if somebody needs them acutely, but if somebody was averse to surgery or not a surgical candidate, this would be a good therapy for them. I think I was going to do a little bit about Silas, talk to him, show his case, if that's okay. So again, I feel very fortunate to be here now, and come full circle and see Silas and Sydney here. And, at the time, I was still kind of guest at Baptist, and I remember I was on call, and I was happy to take care of any patients I could for Dr. Campbell, Dr. Neiman, and Dr. Sojo. And I remember feeling anxious when this other neurosurgeon came to me and talked and said, I have this patient I need you to take a look at. He was 17 at the time. He's a high school junior and collapsed, and he's basically extension posturing. His plastic cone score is 4. And I put these external ventricular drains in, and his intracranial pressure was 100. And so for, you know, the nurses and the physicians that take care of patients like that, they think, when we hear a story like that, you know, we draw immediately kind of prognosis in our mind, and we think, this is not gonna be a good case, this is gonna be a tough case. In the military, we did a study. We found that people with Glasgow Coma scores of 4 to 5 with, you know, penetrating head wounds, which is a different thing, obviously than an AVM rupture, but their morbidity and mortality approached 100%. You know, so they're thinking, this is gonna be a terrible case. But you know, I went and met the Turners, and obviously wonderful people, and you know, they were advocating for their son, like all parents would. Met with Aldana, and talked, let's move forward with the diagnostic cerebral angiogram after we identified that he had suffered this intracranial hemorrhage. And Dr. Aldana had done everything he could. He placed bilateral external ventricular drains, and certainly his pressure did remain in the high 90s. And for everybody else, I know you all know, but we'll just say, you know, normal pressure is 5 to 15 millimeters of mercury. For it to be in the high 90s or to be 100, we think it's most likely to be a fatal injury if it's not able to be corrected. So he was able to undergo this CT, MRI. We did a diagnostic angiogram, and you can see here the AVM, you know, they'll come in all different types of packages. And, you know, I know I've shown you some bigger pictures of AVMs, but even this small AVM here can be just as destructive or just as dangerous. And then he really hemorrhaged from likely these two kind of aneurysmal dilations off of the AVM. And, you know, fortunately, it was feeding from one small blood vessel, and we were able to embolize it with actually not too much fanfare. Was able to, one pedicle or one small artery was able to take care of it. You can see here is kind of the before, and then here is the after, and prevented from rebleeding and kind of put him on the path that he needed. Where Dr. Aldana and the nursing staff, physical therapists, and the speech and language pathologist could all get him on his road to recovery. And, you know, I think he beat the odds in every way. You know, I would check the chart. I was flying back and forth between Jacksonville and Washington, D.C. I would check the chart every few days remotely, and I see this young man, you know, showing signs of improvement every few days. And, you know, really kind of was certainly uplifting to me or inspiring to me, you know, to say that the upfront data would tell you that maybe we shouldn't try, or maybe this is a futile case. But then on the back end, say we throw everything we have all the time into these cases, and we can have miraculous outcomes. So, and this is a perfect case. And so I thank also Silas and Sydney for coming here today, because we don't always get that. You know, I think we're all human, right? We get siloed in our daily work, and we can easily forget the overall outcome of the fruits of our labor. So thank you so much for coming. It really, before I let them take the stage, if there's any questions about what I've said, take a couple down.
They would say questions for after.
Okay.
So I want to introduce Silas and Sydney Turner. Silas is the patient, obviously, and Sydney is his sister. The parents couldn't be with us today. You're all hoping, do we have any pediatric nurses? No, we were hoping we would have some of the PQT and the Dr. Avena, but they weren't able to make it. Everybody was on call today. So I do have a video that Wilson has put together to kind of introduce Silas, and then Sydney and Silas will come up and speak for a few minutes, and then we'll have questions for Dr. Akeda and Turner's.
March 12th, 2024 started as a typical morning for high school junior Silas Turner, but he doesn't remember any of it. His mom, Lori, though, says it's a day she will never forget.
I had gotten home and Silas said that he was having a headache. He said, it's pounding.
Lori and Silas's dad, Royce, called 911 shortly after when Silas stopped responding and immediately got him to Wilson Children's Hospital. There, they quickly learned their son's condition was severe.
They all gasped. And I said, what's going on? And they said, there's blood. And I said, where? And they said, on his brain. And I said, is it significant? And they said, yeah.
Within a matter of hours, Silas was diagnosed with an arteriovenous malformation, or a defect in the way the arteries and veins in his brain were formed. Dr. Philip Aldana, a pediatric neurosurgeon who practices at Wilson Children's Hospital, says this high level of pressure on the brain is extremely rare and can make recovery difficult.
If he did not receive the care that he did, he would not be here. We were fortunate to have him at the hospital in a timely fashion.
After emergency surgery, Silas spent several weeks in a medically induced coma. His parents will never forget the first words they heard Silas say.
And he had come out of the coma. And they asked him, it's probably the most powerful thing I've heard. They said, do you know who this is? And he said, Mom, that's my dad. And that was all we needed.
That was the biggest.
That was all we needed.
After nearly 5 weeks in the hospital, Silas was transferred to Brooks Inpatient Rehab, where he spent about a month relearning to walk, talk, and eat. Silas says he wouldn't be where he is now without the support from his parents and older siblings, Royce II and Sydney. As for the doctors and nurses at Wilson Children's Hospital, he says they inspired him.
Shortly before the injury, I started learning major nurses, but after the injury, it especially ignited my urge to do that because the nurses that I had in the hospital helped me so much. I wanted to reciprocate.
The future is promising for the 18-year-old who is the son of two principals. His dad at Paxson School for Advanced Studies, where Silas is finishing his senior year. He plans to attend Florida A&M University in the fall, where he hopes to continue one of his passions, playing the trumpet.
It's been fun. I still know how to play all the notes.
Dr. Aldana credits the team at Wilson Children's Hospital, but also Silas's parents.
His parents are very warm and friendly and have a very positive outlook in life, which I think is a compliment.
Dr. Aldana says Silas is a walking miracle. Thanks to Wilson Children's Hospital, Silas's parents will continue to watch him live out his dreams.
Thank you all so much for allowing us to speak today.
I'm Silas. And last year on March 12th, right after my SAT, I suffered an AVM rupture, which resulted in 2 aneurysms and a hemorrhagic stroke. I then spent my entire summer with the Brooks Pediatric Day Treatment Program doing rehab therapy so I could relearn to walk, talk, eat, and just live.
My name is Sydney Turner. I'm Silas's older sister, and I'm here in support of Silas. He's going to be giving the presentation, but there are obviously some points in the experience that Silas doesn't have any recollection of. So I'm just going to be filling in those gaps and also representing our parents who are at another conference who would have loved to be here, but looking to be filling in.
So before the injury, I was an active member in my school's extracurriculars. I was the trumpet section leader in our concert band and our marching band. I was a Golden Eagle ambassador, which is a group of students at our school that gives tours to incoming students and families. And I was choir president and bass section leader. I also served as the president of the National Chinese Honor Society. I had just been a finalist. I got first runner-up in the Martin Luther King oratorical contest. And I've had perfect attendance all the way from kindergarten up until that day. And the day I took my SAT, when I got home, my mom said my head was, I told her that my head was pounding, and it was a pain that I had never felt before. So, and they asked if I had got sick, they asked if I threw up, and they asked if I felt like I was gonna throw up, and I said I already did. So, eventually my dad came to check on me, and he was saying, "Sigh," and I wasn't responding, so he knew something was wrong. So then they called the ambulance and immediately took me to the hospital.
So from that point, sorry, Scott. From that point, of course, as I said, we knew that it was something serious. So he was taken to the ER and imaging was done to look at his brain. And as my dad said in the video, the team of medical professionals gasped when they saw it. And we're not medical experts by any means, but we know a collective gasp is never a good thing, right? So they eventually explained to us that Silas had arterial venous malformation. Dr. Keita did a wonderful job explaining in AVM. I don't want to say, be redundant in any way, but the way that they explained it was really helpful for us as people who were completely unfamiliar with it. It was just that there's typically a capillary connection between the arteries and the veins, and that was not present in one of the veins for Silas. The arteries and veins were basically bundled together, creating a pretty dangerous abnormality in the brain. So Dr. Aldana told us that he would need to go into a medically induced coma to relieve the pressure from the brain, and that he would need an embolization. This is Silas's first week in the PICU, and the rupture occurred in the ventricles. As explained before, the intracranial pressure was very high. They explained to us later on, we didn't know it at the time, but they explained to us later on that it was a pretty severe, almost, potentially fatal level of pressure. So we were extremely grateful to Dr. Keita for coming in and completing that embolization procedure, doing it so quickly and so masterfully. And the entire medical team was very attentive. We all know that because of how severe the injury was, there could have been room to say, "I'm sorry, it's a case that can't be treated." we already know what these numbers indicate, and it's not worth pursuing, but that was never our experience at Wilson. Everyone fought tooth and nail to make sure that Silas had proper treatment, that the family was taken care of. They were checking on us every 10 minutes in the video. Are you guys okay? Do you need anything? If Silas had a coughing fit, they were there to make sure that whatever it was that was causing that, it was alleviated, that he was comfortable. And we can't thank the team enough for how they took care of Silas and took care of our family and also informed us. Because as people who are in a very unexpected situation, it's really important to know what's going on, you know, to be educated because we're not familiar with these situations. And that's something that they were phenomenal at doing, was keeping us educated on what it was that we were facing with Silas, but also what treatment would look like moving forward. The wake up. So we were extremely excited to see Silas and be able to talk to him again, but we were terrified. We didn't know what to expect. You know, his personality would be the same, if he would remember us, if his voice would be different, you know, you just never know. And but ultimately we were just very excited, and he was very fatigued. So tired, like I've never seen him. He was really impacted by the medication. He was weaning off of medication from an 11-day medically induced coma. He had left side neglect and weakness. His voice was very hoarse, and he only had a few words. His eyes were fixed on the wall, so we would be talking to him over here, and of course he wasn't looking at us, and that's okay. You have been through a lot. But we also noticed that he was very sensitive to motion, so anytime he was adjusted in the bed, he was nauseous immediately, and we would find out later that would continue for quite some time. I'm a speech language pathologist in the school setting, so I'm partial to therapy. I had to put some therapy videos in there. This is him with his speech therapist. This is a video of him in the PICU working with his awesome speech therapist, trying to initiate swallowing. That's our mom. And that was progress because it took a while to be able to kind of close his lips and be able to even initiate the tongue movement. This was his team, his OT and PT helping him to kind of initiate standing up in the early stages. The Wilson team was phenomenal. We can't say it enough. Every member of the team, the CNAs, the nurses, the therapists, the musical therapists, I mean, the respiratory therapists, every member of the team was really awesome, and we couldn't be here without them.
I owe my life to you guys, and that I'm forever thankful. So thank you so much.
But if we're running over time, we can. Thank you all. So we're just gonna get through these really quickly. Brooks rehab was phenomenal, and that's where Silas spent a lot of his time. Once he was talking more, we realized that short-term memory was primarily impacted. So that was a really big hurdle to get over, and we learned about confabulations.
They described to us that the simple term for confabulation is honest lying. The brain fills in gaps in the memory with details that seem true. So I would talk to my sister on the phone and give her descriptions of things that happened to me during the day, and none of the things I told her were real.
Really quickly, we have a clip of Silas learning to walk and kind of build up some endurance and stability. Just go to you, Alicia. Still really fatigued at the time. And very quickly, Silas can talk the most about outpatient because that was when his memory was starting to improve and he has more recollection of that experience.
So the Brooks PDP program, I was there 5 days a week, 3 hours a day. We were doing a lot of work. I was getting work physically, cognitively. I think that's it. And occupationally, that's kind of a word in both of them, so that's nice. But the therapists they worked so hard with me to get me back to my original state. I was fully recovered physically by the end of therapy, so I was able to go to band camp over summer and learn the music. I actually memorized some music in therapy that I would play during the year before some of the people in my band did. So when I got there, my band director was very impressed.
Silas and I were practically in the program together all summer, and one thing that I loved was that they always focused on getting him back to doing the things that he loved and that were important to him. So this is his speech therapist, Sarah. She had him playing the trumpet as he was memorizing the sequence of color tones to go to. And Silas was just working super hard to build strength and coordination, as he said, and build up his strategies to remember in the absence of some short-term memory. Last video, this is one of my favorites where he's racing his physical therapist already. That team, and now this is the end, just talking about what Silas is doing now as a result of the amazing care he received for the entire period of his care.
So I was glad that I was able to come back to school and rejoin the marching band. Still resume my place as trumpet section leader. And I learned 2 shows and 2 dance routines during this year. And I retook my place as bass section leader in the choir. And it's been a challenge, but I've been making my way through. And I had my 18th birthday party at Top Golf with all my friends, so that was special to me. I joined the National Honor Society. I competed in the Martin Luther King oratorical contest, which I also did last year. And this year I received a prize of $1,000, so I was grateful for that. And most recently, I went on my school's Europe trip, which we have been planning since last year. So I was glad that I was still able to do that activity. And what I plan to do next year is, starting in fall, I'll be attending FAMU and the pre-nursing program. I already wanted to do nursing before the injury, but experiencing what I went through kind of ignited my passion further to do that. And I already auditioned for their marching band, the marching 100. So. It wasn't probably great.
Our final thing is just a thank you from our parents who couldn't be here, but wanted to share how much this experience and the Baptist team meant to them.
I said, we want to thank you all so much for taking care of our child. Thank you for saving Silas's life and for making us a part of the entire experience.
From everyone, from the emergency room team to the doctors on the pediatric floor, ICU, all the therapists, the dietary staff, the respiratory team, everyone involved, we want to say thank you because all of you have contributed to helping us get our son back, and we can't say it enough, but we will try anyway. Thank you. Thank you all for being a part of our family.
Thank you all for coming.
I feel like we should allow for a few questions if you guys have any. You have a question.
I have a question. I'm gonna start, it's not a question, it's a comment. I cannot say thank you enough, mom and dad not here, but this, inspiring is an understatement. My father, I have a sister with a speech pathologist, I found something else we have in common. And proud of the whole work, I did not say the name of Philip Aldana. There's our fearless leader for the pediatric neurosurgery at Wolfson. Again, the work that we do at Wolfson, I'm very glad to be a little part of that because through 2008, a kid like Silas would have been flown to Gainesville to be taken care of over there, and you would waste 2-3 hours of that precious time because of this union of forces between adult neurosurgery, pediatric neurosurgery. These kids don't have to leave Jacksonville anymore and have the superb care that we have at Wolfson. So it's super inspiring. We go through a bunch of punches, not only when you have an AVM, but life, you know that you still grow older and older. The older you get, the more punches you receive. That's normal. But we can never lose decide what we do every day. And this goes for every single layer of top administrator to everybody in the hospital. We are there because of new science. And if we miss that, I think we miss everything. Your story, your willingness to share, for me, super inspiring. Thank you, Dr. Aldana, Dr. Ikeda, for sparking that. And as you said best, and your mom and dad said that, is a whole village. Everybody from the OR, Brooks Rehab. Again, that's heartwarming to see a 18-year-old marching band. By the way, if you have not signed yet, there's a contract for a Wolfson nurse position waiting for you. Before you go to nursing school, come talk to us or connect to Lars, connect to Alec, at our hospital, because I'm sure they'll sign it before you go to school. You will be like awesome nurse. Because not everybody has the experience that you have, and I'm sure you're gonna care, just like mom and dad, like your sister. You're gonna care for people. That's what this is about, caring for people. Thank you, my friend.
From the audience? Okay, that's gonna be a tough act to follow. Okay, thank you guys for coming so much. We're so happy that you were here to tell your story. Thank you. You're fine. Yeah, I did have another announcement that I was. Right, so, we do have our banner hall. I want to make sure that you guys saw them, our sponsors. They've been so gracious to help fund this event, all of us. So, in order to invite you into the vendors, we have a raffle. So if you, we have a little contest. So we have these cards, which I think are in your bags. They're in your bag. And you'll take these and get stickers from all the different vendors and then give them to us in where. Okay, we'll have a basket outside where the registration desk. If you give us those, at the end of the day, we'll draw one and you'll be eligible to win a basket full of all kinds of goodies. I promise you don't want to miss. I think there's a special, there's a special prize from one of our physicians and it's an honorary circle member. You don't want to miss that. So, definitely turn your cards in. Okay? All right, without further ado, I'm going to introduce Ebony Green. She has been kind enough to join us for the second year in a row. She's going to talk to us today about lumbar drains and EVDs and subarachnoid hemorrhage. We have quite a few subarachnoid hemorrhage to us today. So buckle up. And Ebony, we're so thankful to have you back. And welcome to the stage. Hello. This is the unlovely slide. That's very hard. Also, why I don't forget is because I don't think I would have made it as the nurse session at the year. I would have been like on the floor. So I'm Ebony, we're gonna talk last year, we talked about my dual exhausting that I did at the University of Arkansas. With EVDs and lumbar drains when we treat our aneurysmal patients. So this is just kind of like an expansion of that practice that we still do. These are the objectives. So just kind of an overview of subarachnoid hemorrhages. We all kind of know, I'm gonna cheat for a second. We all know aneurysms, ruptures is weakness in the blood vessel wall. It causes lots of things to happen, as we've seen, like even the ADM with the patient who shows here with virus. And a lot of times it's a kind of like headache, the worst headache of the patient's life, and they usually end up in the ICU with us. So the importance of cerebral spinal fluid, it bathes your entire body. So I used to tell people that it's like a 2-liter, which I guess is still kind of true. It's how much you make in a day, about 500 mils of cerebral spinal fluid. When we're draining off that amount, of course, you tell patient's family a number, and they're like, oh, what's happening? I see like there's 50 in the beer tall, but you know, are they gonna make more? How are they gonna make more? Why are you drinking this off? Why does it look like Kool-Aid? And explaining all those things, as just saying, it's important to explain to all of our patients what's happening to them. That they were an awesome family, because I don't know how many families would have been able to see a number of 100 or 90 or 23 on a screen and not be like, oh, this is what it is. So I mean, that's a testament to them and to the education that was done by those bedside nurses to keep them calm. Again, I would have been on the floor with them, not able to have a conversation about somebody's pressure that was greater than 100, greater than 90 for any amount of time. So in subarachnoid hemorrhages, usually that blood leaks into your cerebral spinal fluid, and so you have to find a way to drain it off to get rid of it. Most of the time we place an EVD. At my facility, you get dual exhaust. So prior to going to the anterior suite, typically before going to the OR, because we do open and endovascular, you're going to get an EVD and you're also going to get a lumbar drain. We call it the trifecta. So you get EVD, lumbar drain, ET2, and if you're really lucky, you may even get a central line. I don't know why they don't do central lines. You thought I was going to say like, oh. Nobody thinks about that. What are you talking about? So the placement for lumbar drains in my post-aneurysmal patients is the anticipation of how this blood
accumulates and settles in the basal cisterns, how we can drain it out. So it's not every single patient is gonna have a high interventricular blood burden when they have subarachnoid hemorrhages. Not enough where it's gonna do stuff, especially if you're talking about a traumatic patient, meaning that they were driving when their ears are ruptured, so they have a broken extremity or something, and then you have the ortho team that's like asking you, like, why can't I do like 100 milligrams of Lovenox twice a day? And I'm like, do you see the blood that's in there? Why can't I do Plavix? That's a big one for me when we have people with femurs. They always ask me, can I start Plavix today? And I'm like, never. But so draining from the top and from the back for us helps, one, keep the pressure monitor, which you can also do lumbar pressure. We don't practice it in this type of patient, we practice it in my spinal cord injury patients. So we're just using that top as like a pop-off valve. So usually it's closed, it's not gonna be open. If someone's pressure gets above 22, 23, depending on what they're doing. We also have piezometers wherever, then we're going to open up their EPD. Their lumbar drain is consistently running somewhere between 5 and 7. The magic of that is just neurosurgery voodoo. So 5 is because it's easy and for everybody to remember. We go up to 7 just because we're like, ooh, they're really pulling a lot, or their blood is really thick. Again, there is not a lot of data behind it. It is mainly going off of your patient. So this is where those astute neurocritical care, neuro ICU nurses, nurse practitioners come into play when they start to see the changing of the color and the consistency of the EPD of the lumbar drain. I am still a fan of wine, so we go from a Merlot and then it starts to become like a blush or a rosé till it gets to like, I love bubbles, until it gets to like a champagne color prosecco. Then we're like, we've made it. This is where we want to go. We know the blood's coming out. It's very easy. Most of the time I end up having to compare it to hard liquor, which makes it hard. Like it's either whiskey or it's tequila. Obviously, I'm a bubbles person. Also, this helps with preventing vasospasm. Again, there's not a lot of literature, not a lot of data that supports that. It kind of goes either way. I mean, you can do a complete research and you'll find people who had great success and you have those that don't. It's again, the practice and what you're used to. And it takes a lot of getting the buy-in from stakeholders, because I will tell you, we do this at my facility. We're the only level of trauma in my state still. I do have a chair now, that's a new thing. But the other 2 hospitals who also take care of, who are comprehensive stroke centers in my city, don't do this. You get an EVD and that's it. EVD, no EVD. They don't do lumbar drains, and it's just because of the practice of those providers there. And I did raise them, so they know how to do it. Of course, anytime you're putting a lumbar drain into somebody, you're putting anything into anyone, there's a risk of infection. You worry about, because you never have someone who isn't on something. You're on aspirin, BC powder is still big. I watched somebody buy BC powder like on my way here in the airport. I was like, I wanted to like knock it out of his hand, and then I was like, don't do that, that's assault. But like, why would you still sell BC powder? Then of course, having the dual exhaust, so you have an EVD and you have a lumbar drain you're worried about. Upward and downward, down herniation, that's a real possibility. You worried about if there's any midline shift. Of course, you're looking at the scan and looking at your patient and seeing what's happening. Again, a lot of times, because these are controlled by the team, I can clamp the EVD or the lumbar drain. If anything happens, I don't typically have them running both at the same time. I can run them both at the same time. It also depends on what's happening with the patient, depending on what day we are with our subarachnoid hemorrhage as well. So a little bit of review of anatomy and physiology. So here's the CSF that's flowing. I usually tell people, you think about coral and how the ocean flows over the coral, like that is what the CSF is doing in your body. I always try to get visuals. And it's consistently bathing it. And you produce this about 75-ish every hour. And if we were to drain all of your CSF, not that we ever would do that, because that is ill advised. But if we were to do that, it would take you about 7.5 hours to reproduce that amount. Now, the patients that we see in the ICU who have all these tubes in them, that we're draining this Chablis or Merlot off of them, we're helping to filter out their CSF so that the ocean can continue to flow over the portal. Because if there's blood or debris or trash or pollution in it, it doesn't flow as easily and can clog up these systems. I know, and I don't work with kids, but that's usually how I explain everything to everyone. So, ultrasounds are taking over the world. If Diane was here, she'd be very excited that I included a slide that had an ultrasound to do a lumbar puncture. I am still a landmark girl. I do bring the ultrasound in there. I do teach landmarkings with the ultrasound, mainly because a lot of times fluoro isn't going to be readily available, meaning I can't take a patient down to an IR suite to do a lumbar puncture or to place a lumbar drain. So I have to do what's close to me. And I usually still the ultrasound from the trauma ICU and tell them I'll bring it back. I'm like, oh, look at that. You know, I'm not going to take it home. It's too big for me to put in my heart. And so this is just kind of the markings. And I literally lay a patient on their side. Sometimes they're sitting up, depending on what's going on with them. And I'll mark out with my surgical marker where I'm going to go. And I'm talking to the patient and to whoever's in the room with me as I'm marking and as I'm doing this lumbar puncture. It gets tricky when you have patients who've had spinal surgery before, who have compression fractures, who may be unlucky and have some other like cancer that's happened, and now they have a ruptured aneurysm and now you're doing a lumbar puncture. Also someone who may be shot in the head and then they're trying to get them to comply with whatever you're saying and you know that they're not going to do it because they're 1000% frontal. But this using an ultrasound it's helpful at the bedside and I have incorporated it into my practice. Also as a nurse practitioner, I shoot a screenshot of this, I put in the patient's MRN and then I use it to bill for my bedside procedure because it kicks it up about $1.5 grand whenever you have a picture that goes with it. Why a picture matters when I've been billing without one for forever, I don't know, but we play the game. So this is not with the chest tube, but also I've seen that. But this is kind of just like the positioning for a lumbar drain. This is not what I currently do, but this is what sometimes has been done where you insert the lumbar drain, you have it draining to gravity, you clamp it, you wait for those precious 5 to 10 mils to drip, drip, drip. The patient can't do anything, they're laying down. Somebody calls you on Vocera that your patient's leaving AMA and you're like, take it. And you look back and it's like 27 mils have dripped out and you're like, fantastic. Which is why we do it on a pump. So here's just some things that can happen when you are doing lumbar punctures, the risk of bleeding, the risk of infection. When you're doing a tap without putting in a drain, usually there's 4 tubes that you try to fill up. Typically, if someone has blood in their CSF space, this is what's going to be done in the ER, then you're looking for that blood to clear by the time they get to the 4th tube. To determine whether it's a traumatic tap or not, you're looking at your CSF studies, you're looking at your cell count, your glucose, your protein, your white blood cell counts, and your red blood cell count in that. So when you're positioning a patient, some of the considerations for the allied folks, all the folks that are in the room, you want to make sure that you're doing it with care, treat it just like any other IV. If the patient's getting up and going to the bathroom, if you're putting them on a bedside commode, if they're wanting to turn, or like I do, and this is appropriate for Florida, I have patients that like to elevator roll, which means I never sleep on my back, I always sleep on my stomach, and they just like roll everything up, and you're like, how did you do this? And it's magic, because you can never get it out. And then, of course, ensuring that the drainage is proper, so if you're supposed to drain 5, you're draining 5, if it's 7, if it's 10, whatever it may be, the color of it, thickness, if there's anything floating in it, any debris or anything, that's documented. And then also managing those patients for those CSF headaches. Like I drained 5, but my head still hurts. Or we went up to drain 10 and now I feel completely better. So monitoring those things, because the nurse, the bedside direct care nurse is gonna be the person that's gonna report it to the team, and then my resident's gonna take credit for like being magical. We fixed them, and I'm like, you did nothing, you wrote an order. Congratulations. So some potential complications. So, definitely nerve irritations with lumbar joint patients, those are the largest things, like you will hear people scream and say, I just felt an electric shock down my leg. And that is from, the nerve irritation. Usually it should go away. If it doesn't, dig deeper. Risk for infection, especially if your provider has pooping hands, which I do get on people all the time. I'm like, you sneeze, you touch your glasses, like you broke sterility 500 times and they don't ever think about it. I make them change in the middle of it, and I empower the bedside nurse to make my other providers change gloves, wash their hands, all these things. And this last one, the catheter tip remaining in the patient after it's being removed, has happened twice to me in almost 20 years. Both times we have to do a laminectomy and take it to the OR. In both of those situations, it was, I blame the doctor. It was them not educating the patient on what was happening. So, hey, the same way I put it in, it's the same way I'm gonna have to take it out. If you straighten your leg, if you arch your back, if you move anything, there's the potential that I could shear this very thin piece of plastic off on, one of your vertebrae coming out, a piece of bone on the way out. And that is what happened with both patients. One was a man, one was a woman, one was young, one was old. But both of the residents were boys. So there you go. They know. And we took to the OR and did laminectomies. Now imagine doing that consent. That's how did this happen? This is where you double check and make sure on the original consent to put the lumbar drain in, you included like retained fragments. It's on all of our, like they're printed out now, pre-printed, but it says that now, because of this experience, and it's, never fun, and you go and you look in OR, put somebody under general anesthesia, because you're doing a laminectomy, to take a piece of plastic out of their back. They are radio-opaque, so when the catheter is coming out, you check, the provider checks, whoever's pulling it, make sure that they have that tip all the way, just like when you're taking out a Foley and an IV, make sure nothing else is retained. These are radio opaque, so if you feel like you've left a piece, or you're like, man, that hole looks really big, when it's usually the size of a pin, get an x-ray, shoot an x-ray, and you can see if something's been retained in the patient. Let's hope it didn't happen. But what I do is a lumbar drain on a pump. So we have two different things, and I've tried them both, and I don't like this one. That's the picture. I'm not going to name it because we call it the death machine where I live. But components of a lumbar drain, this allows your patient to be mobile. This allows your nurses to be able to go and take care of other patients. This allows you to trust it, just like you trust your IV med pump to drain off the calculated predetermined amount of CSF. With this machine, you can also do the pressure, which is why I have used both systems at my facility, because for a spinal cord injury, I do want to know the pressure because I'm worried about stroking the cord. But for cerebral images, it's not something that we're really worried about the pressure. It's not something we're worried about. So again, making sure they use sterile technique. This is getting an opening pressure, which I still like to get an opening pressure, even though I know I'm gonna put a drain. You have all this up there, why not get it? Is usually what I end up saying. Using images, so point of care, ultrasound, getting an x-ray, asking the patients and their family, have you had any of their back surgeries before? Have you ever been told that your spine is weird? You wanna make sure that you're not gonna hit their core just because they may have some type of abnormality to their anatomy. This one. So this is a video of how that all of my nurses on my progressive floor in my ICU used to put together a lumbar drain. So these are all of our supplies. So these are all our supplies. Okay, make sure you see it. That's Jessica. I know, can you tell she was really happy that I made her do this? So these are all the things we get together so IV pole, single channel, dedicated pole, dedicated channel, a 250 ml bag of normal saline. Doesn't have to be 250. I'm only gonna use 50, so you could do a 50 ml bag, but 250 is usually the smallest one we have. But in the scarcity of normal saline, you know, you don't wanna waste more than you have to. And then the lumbar drainage kit, and EDM is just like the brand that Medtronic makes, and that's just what it's called at my facility. Having a Lure Lock, connector, stop pop with a rotating male collar. Of course, other people tell you this is a two-person job to make sure everybody's double checking. Heroes caps, which are those green caps that are there, sterile gloves. Those aren't sterile, but sterile gloves. And then, clean gloves just for the person that's helping you. So we prime it, wash your hands. Prime it, empty the saline, and then I tie it off. I leave that empty bag connected for a couple of reasons. One, sterility. Two, because it helps, like I usually write on there, like, do not remove, this is not empty, look at the other pumps. Because someone's gonna help you because they hear a beeping and they're gonna go and they're gonna be like, oh, you're out of this. And then like, you know, before they know it, they've like disconnected your lumbar drain. And I'm like, that's not it. So I usually write something really nice, not nasty on it. So the gloves, this is everything that comes inside of my kit. Of course, this is just reminding them of sterility, dropping everything on an open sterile package. The nurses are putting this together and the providers are connecting the patients to the lumbar drains, but everything else is done by our bedside nurses. The tubing that I like to use, and I call it CBL tubing just because at my hospital, the CBL tubing, pressure tubing is blue. I don't know why, but it is. Has that blue stripe on it, but that's the stiff tubing that I like to use, not PCA tubing. I've tried it with both. And then this is just how you connect it to make a beautiful love connection. To extend, and why do you want extension tubing? Because I'm putting you on a pump and you're gonna walk around and down the hallway with PT and OT, you're gonna go to the bathroom, you're not gonna take a shower, that's the only thing we have to do. And then we're connecting all of our tubing, we're flushing it with, priming it with normal saline. I usually run that whole 250 ml bag all the way through and drip stuff on the floor, and I clean it up afterwards. Then I'm connecting it. The patient is the secondary. Your patient is your IV piggy bag. Your patient is the little split port that comes off. So if you need to inject, withdraw, whatever, your patient is your IV piggy bag. Most important things to remember. So we're grabbing the stop top, we connect it, we put it all together. Connect the rear trawl. The rear trawl is connected to the end of the primary tubing that I'm putting through the IV pump. Because I'm leaving that secondary part where my lumbar drain will connect from the patient. Prime everything up. Now it's time to call the resident. Yes. Anyway, so making sure that we grab this kit for them or for me. And a lot of times we're putting in lumbar drains on those patients that have infections, those patients that have CSF leaks. A lot of times I've used this for my transfemoidals, they get a lumbar drain, so not just for my subarachnoid hemorrhages patients. Use this for our transfemoidals. If I externalize a shunt for somebody that comes in with a lumbar peritoneal shunt, they get this as well. And then also when I get the pleasure of spending 3 days with my geriatric patients to rule out more pressurized hydrocephalus, this is also what we do for them. And then care of the lumbar drain. See, we have it written, lumbar drain, it's solo, it's by itself. We write a little happy reminder note for the people who are trying to help us when they hear beeping. We set it for a rate, set it for a total volume for every 2 hours. So if it's going at 10 mils an hour, your total volume is 20. So at 20, you know that you have to go back in and check on this patient. And every 2 hours, you're doing a complete assessment of their entire lumbar drain. So not just looking at the pump, but looking at the back, looking at all your connectors. Because, you know, neuro patients, they like to fidget and touch stuff. And so they'll unclip themselves. And then next thing you know, you're like, why is there a halo on your chuck? And it'll be because they disconnected the stop pump. Usually I wrap them with tegaderms too to help prevent that or give you a little bit of time. So these are some things that can happen. Over draining, under draining, These are what scans look for, infections, just reminding them, because again, the person that's gonna notice that something's happening with the patient is the nurse is taking care of the patient. And these patients are not admitted to my ICU. These are patients that are on the regular floor. It's usually a 3-to-1 assignment. So 3 patients, 1 nurse, they're considered progressive. We do everything every 2 hours for them. So, my nurses know that they can call me and say, I think this person needs a scan because, and usually while they're saying that, I'm coming to wherever they are and that order's already in and they've usually already called CT and we're going. That's just the relationship that we've built from me working with these nurses very closely. And they also teach my residents too. So if it becomes disconnected, the patient fidgets with it, and this is what you find. This is kind of a little safety kit. So on my crash cart, I have something for ACDS for airways. I have an emergency airway box for emergency intubations, and then I also have my lumbar drain safety kit, which has all this stuff in there. So you don't have to walk into the Walmart bag, into the Walmart room. That's what we call our supply closet. Also I'm a Walmart, Arkansas. So back into the Walmart room and then try to find all this crap, just get it and have it and then roll. So here's a video.
Right now, you know it's time, you're gonna go through and open all of your supplies. So these 2 packages come in the box that you get off the shelf. One is the drainage bag, and one is the. We're gonna do is open them, be mindful of the sterile signs. So now that's open, what I do is I drop my other supplies onto the bag, because the bag is gonna be the last thing that I do.
Until she's been yelled at for like dropping us on the wrong. I might have get it. Also probably making her nervous while filming her, making her do this.
Alright, and now you put your sterile gloves on. Now that sterile gloves are on, you're gonna need a partner to be able to assist you if you need help with the issues. Alright, so once you open these cases and you have all of your supplies, the easiest way to set up the drain that's foolproof, the book didn't really go into it, but the way that I have made it to where I can do it rather quickly is opening our package and taking off the blue tubing from the existing stock. If you notice in the old book, it talks about male and female ends and what end connects to what, but these 2 ends are the same. When you go to connect your stock box that you got out of the supply room, not the one that comes in the package, you're going to disconnect from that and get your new stock box. On the stock box, this blue tubing only connects to one end. So that's the end that you're connected to. Also, when you're in the warmer room, you pick up another cord. You're going to screw it on to this side. Now we made that part. You then have 2 sets of 34-inch extension tubing. The ends are opposite, but they will connect to the stock here. So you will start on the piece that connects to the only piece left. Connect your second set of extension tubing to that piece. To the end of that extension tubing. So now you have 2 sets of extension tubing connected together. the stop cough you got out of the warm room to the blue tubing that came in lungs. This is for your power coming in. You'll have them carefully open a couple of questions for you, and you're going to found these tubes. So. You'll connect to the cord. And just move your thing back and forth to where you can fully ground one. When you get off to the blue side, which is essentially your patient, you'll disconnect from this, throw your flush away, and you're going to connect the end of the extension set to the secondary port and the primary set of tubing. Go next with that. Once you're done with that part, it's easiest if your curious caps are hanging already. You'll go ahead and put that corner of this port. You'll place the cap on the blue.
And that blue line is what
You drain is these.
what you're gonna give to.
It's the second half of the drain.
Back to my other side, thank you. So the blue part is what you're gonna give to myself or the resident that's gonna connect to the lumbar drain that's coming after your patient, so. A little bit better visualization of when I say like, this is the patient side of the piggyback. So hopefully that makes sense. So lumbar drain, weaning and removal, if I have a patient that has, an EVD and a lumbar drain, usually my EVD is the first thing to come out, and then I'll leave the lumbar drain, and I'll wait for the lumbar drain to change to the color of champagne. For removal of a lumbar drain, usually it's pulled by a provider at the bedside, a monochrome stitch is thrown in, and then the patient, lays flat for an hour. Max, usually they don't really have to lay flat for any longer than that. And then the biggest thing is to monitor for CSF leaks, monitor for changes in the patient, headache. We've been draining them for such a long time, especially if we're talking about vasospasm, so through the vasospasm window. So anywhere from, 8 to day 8 to day 21. So their body is probably getting used to that. We can also send CSF from those lumbar drains if we needed to, if there was a question about infection, if you, the tubing kind of changed colors, looked murky, you had an axon disconnection on one of the many road trips to CT or MRI. Now, what we use these lumbar drains for in our subarachnoid hemorrhages is to help improving the cerebral perfusion. Like I said, we're clearing the blood. We have something to monitor the pressure that's in their head, depending on their IVH, their blood burden. My EVD is usually set at 15 or 20 millimeters of mercury. I'm going completely off of what the ICP and the patient's exams are. And then I'm using my lumbar drain to clear those basal cisterns so that I can keep removing all that blood, because they're laying flat in the bed, the blood is settling because gravity is making it settle, and so it's much easier to pull it from the lumbar spine than from the CSF, from the lumbar, instead of from the EVD. Of course, all of our favorite nursing interventions for vasospasm, everybody's favorite pneumotophene, and how it trashes your pressure, and we end up having to go in there for 2 hours anyway to give somebody some nasty medicine. So we're gonna talk about a case study in my last few minutes. So this is the head CT of my 40-year-old patient. So 40-year-old female, past military history, depression, polysubstance use disorder, and post-traumatic stress disorder. She had an unwitnessed fall after a night of fun. Woke up with like some confusion, dysarthria, friends didn't think it was that abnormal. But when she did fall, she did lose consciousness. So she had a CTA that showed that she had subarachnoid hemorrhage, some IVH, and she had hydrocephalus, which is HCP. She had a modified Fisher of 4. We loaded her with Kepler because why wouldn't we? We started on a cardiac drip. Her pressure was somewhere in the 170s. We would like to get her down somewhere close to 140s. Again, depending on what substance and where she normally runs, her patients normally run, I may not lower their pressure that fast. It just depends on what their scans look like. Her, because she had subarachnoid blood and IVH and she had hydro, I wanted to get her down fast because that blood is just gonna make it irritate the pressure more. So her CTA showed that she had a left posterior communicating artery aneurysm. This is all while she was in the ED. She is admitted to neurocritical care. She gets dual exhaust. We do that prior to her going to neuro IR where she did have an embolization, or pulling, excuse me. Of course, afterwards, she was extubated because the poly substance use disorder helped to act as a preservative. And so she was able to be extubated. Claimed her EBD, and then I ran the lumbar drain at 5 for days 8 through 14. I waited for it to become clear. I didn't ever have to go higher than that because the blood was getting cleared out so quickly in those days. And she was a thrasher, alligator roller all the time. So EBD was clamped. I removed the EBD on day 8. Vasospasm with no TCDs were normal. They had trended normal for a couple of days. And then I pulled the lumbar drain out. She could have gone to the regular H8 progressive floor with a lumbar drain. The EBD was the only reason that she was in ICU. Okay, and then these are 2 trials, the LIMIS trial and the early training trial. They're both printed. One is a meta-analysis, and the other one just talks about using it was a facility that had lumbar drains in 270 some patients that had subarachnoid hemorrhages, and it was really inconclusive. It couldn't say whether it was better or worse in helping them. Again, it's preference and practice. So here are some AHA and ASA guidelines with your next speaker had a little hand in helping write those things. And here are my references.
I'll ask a question always. I love this protocol. I've heard you talk about this before. So, and maybe you had a slide on this and I missed it, but tell us, since this is a little, I don't want to say unconventional, but it is a different mechanism by which we drain. And I work with a provider who's using more lumbar drains as well. What are your organization's like risk of complications with this? Have you guys been tracking it, or is it something you're going to do? What does that look like for you guys?
So we've been using this method for 12 years, 13 years. That's how long I've had this job. Kind of perfected over time. And now it's truly a timing and color of it. Now we do have the infections, but I will tell you, none of the infections have come from the lumbar drain. It's been from poo-poo hands from my residents putting EVDs in.
Yeah.
And the biggest complication is when the patient has disconnected themselves from the pump, because again, you have lumbar drain tubing that's coming out of your back, and these are frontal people, and they've untwisted it, and so they've had over drainage and had a headache. So we've had a spike in vasospasms, not in radiographic, but like in clinical vasospasms. So pressure was crazy, heart rate was crazy. Patient had a decline where they were kind of obtunded for an hour or so, and then they recovered. So they've been accidental or incidental complications, and that's 13 years of.
That's terrific. I love to hear that. Are you using these, this same method for like NPH trial patients as well?
Yes. So I admit NPH patients, and I tell them they're gonna be with me for 72 hours. We have neuropsych and PTCM before. We do the lumbar drain, and instead of doing a high volume tap and see if they improve, we drain them anywhere from 10 to 20. Again, it depends on what their skin looks like and what the patient can tolerate, and then they're seen by PT and psych every single day. And then at 72 hours, we clamp it, and then they're re-eval.
Nice.
So,
Thank you.
Any other questions?
How many organizations use this practice, and do you have any clinical trials that you're actually running to like prove that it's better than the conventional method that we're using right now, like a comparison?
So, there are several standard lumbar drains that people are using. I still use my unconventional but off-label use of my just Alaris pump. That's the med pumps that we use in my facility. My past chair came from Colorado, from Denver, and this is something that he used there. So the University of Utah, University of Colorado, both have heavy documentation over the last 20 years of using this as a practice. The play has come to whether it's more standardized versus what we do for off-label use. And the only benefit to using a prefabricated, like LipiGuard or Medtronic or Natus also has a system using one of those, is that you're able to monitor the pressure, but that's not really beneficial in subarachial patients. And then, like I said to Kippen, most of our complications have been incidental, low risk infections. Patients, usually their biggest things they complain about, having to lay on their side for the puncture. And I make my residents use ultrasound, so I'm not digging for gold. And it's the nerve irritation. And we did publish this 5 years ago in the Journal of Neuroscience Nursing. I published in nursing.
Thanks, Ebony, that was great. Okay, so up next is our longtime friend and colleague, Kippen here, from Chicago. She's gonna talk to you, we're really talking about the rapid July today, so like hopefully you guys don't get too bored. You know, we love this topic here, and I know our ICU is really into this topic, so Kippen's gonna talk a little more about delayed cerebral ischemia and you know, favorite words. Welcome back.
Hi, everybody. My name is Kippen here. I'm from Chicago. It was supposed to be warmer here in Jacksonville, so I'm a little disappointed. Had to get my little jacket on today. Just for read of the room really quick. Just want to understand how many in here are nurses? Awesome. How many are therapists? Okay. I know we have our emergency department. In the ICU, stroke floors, coordinators, managers. Awesome. Okay. I just like to see like when I'm talking, like the topic and who might really, you know, what you guys are going to get out of it. And because it really depends on the space and environment where we work. I've been in the space for a long time, and I know sometimes I feel a little boxed in because I get like this narrow vision of like, oh, I've got to stay focused on this. And you're like, oh yeah, there's other organs beside the brain. Really? All right, these are my disclosures. I actually do work for Medtronic now. I'm a Joint Commission Reviewer. I work on conference organization and sit on the board. But sadly, too, like our earlier speaker, no financial disclosures. I would love them someday, but that's probably never going to happen in my lifetime now. Objectives for today, these are them. I hope everybody walks away with a little something. I will say, when I was talking to Wendy, I was like, really, vasospasm? You want me to talk on vasospasm and DCI? Okay. It's not the sexiest topic. I'm just going to say that out of the gate this morning as we're enjoying our coffee, but it is a very important one. And so what I'm going to try to do today is really review management and what our guidelines are telling us and what it should look like. It might resonate more for some of you that are doing it. Maybe it's going to highlight some of the work that's coming, a little bit of what we've done historically and what's new. And when we really think about the guidelines, we have to consider our phases of care. Really, we're looking at our patient through the continuum, always looking in that hyperacute phase. Early brain injury occurs obviously in those first number of hours. Then we really start to think about where we want to focus our attention in that acute care phase, and that's really in preventing delayed brain injury. And that's really where I'm going to kind of focus my discussion today, and really thinking about what are the causes of secondary injury and what are we really worried about? Well, we are worried about delayed cerebral ischemia, sodium dysregulation. It occurs a lot in our aneurysmal subarachnoid patients. What can be some systemic complications for these patients? There's a lot of them. Infection. Ebony just talked about some of them as we put in lumbar drains and consider over or under draining with hydrocephalus, infections. Fever and temperature management, glucose nutrition. Not going to pay attention to those things today. We're really going to focus on DCI, and I'm going to talk just a little bit about some sodium dysregulation, mostly intravascular volume management. But when we think about vasospasm and DCI, a lot of us as nurses, at least those of us that grew up in the ICU, and I was a neuro-crit nurse for 10 years before I went on to do other things as an advanced practice nurse, but I always was like, oh yeah, we're just monitoring for vasospasm, TCDs, we're doing neuro exams, but really there is a stepwise process that we really should be considering how we're managing and monitoring vasospasm. And it needs to start with thinking about what is step one? What are we doing in terms of monitoring for this patient? What is your approach? Do you have an algorithm by which you're going to pull a trigger to say, we need to intervene and do something for this patient because there's something different going on, or we really have some trends that we're seeing that are potentially predicting DCI for this patient. So what interventions do you provide? What are the triggers to pull the interventions into that patient care plan? And then does your hospital actually have the resources? So when we think about this, we do look to our guidelines to help to detect some or to talk, sorry, my watch just beeped. This is the problem, we have these smartwatches, they're very distracting. And I have somebody tearing up my bathroom right now, so I'm a little unnerved at it at the moment. So we look at our guidelines for monitoring and detection of vasospasm. And so keeping in mind that class of recommendation and level of evidence is really important. It should be helping us understand what's the research behind it, and is it really proven? Have there been some strong RCTs that have supported these interventions? So when we look just strictly at monitoring, CTAs and CTPs are useful in detecting vasospasm and predicting DCI. Talk a little bit more about that. TCDs, we all know it's kind of a regular that we should be seeing in our ICUs in terms of detecting vasospasm, also predicting DCI. Continuous EEG. This is something that is reasonable to consider for our high-grade subarachnoid patients. So for those high-grade lesions or high-grade bleeds, if you have continuous EEG capability, you should be thinking about it. And then also in our high-grade bleeds, consideration of perfusion, partial perfusion, oxygen, brain monitoring with your Lycox or whatever you're using, and then cerebral microdialysis, looking at your lactate, your pyruvate ratios, your glutamate, and if you have capability of microdialysis. When we talk about management, level 1 class, class of recommendation 1 with a level of evidence A is early initiation of oral nimodipine, right? So starting that early, not delaying that, that is a very strong, proven, effective intervention that we can provide to our patients in preventing DCI. Monitoring with TCDs, also strong level of evidence. What else do I have on here? This is really far away from me. Vasodilators, consideration of vasodilators, intra-arterial vasodilators. Sometimes we're using intravenous dilators with some of our patients. We're going to talk a little bit about that. Consideration of endovascular therapies is another recommendation here that is a 2B recommendation. Two things I'll call out that are of no benefit that were in previous guidelines and, right, I do sometimes as I do go around to some hospitals around the United States, I will still see some providers that are providing statins for aneurysmal subarachnoid hemorrhage. Now it's one thing if your patient has that, you wanna remain on it, but don't be starting it for these patients. There's no benefit to them in starting statin therapy and impact on DCI. Additionally, those of us that are old enough in the room to remember care of the aneurysmal subarach patients, how many of you use getting mag drips? Okay. All right, thanks. I'm like, don't tell me I'm gonna be the only one in. Edme, thank you. I know we've got a few in the room. Every aneurysmal subarach patient we used to get a mag drip. They all used to get Swan-Ganz catheters too, but we've come a long way, guys. And so that used to be a regular on what we do, but there's no benefit in giving your patients magnesium anymore for these patients. And what is harmful for the patients is Triple H therapy, right? Used to do that too. Everybody got a mag drip, you got a Swan-Ganz catheter, we pushed your hemoglobin up past 9, we drove your intravascular volume, your blood pressure was like in the 230s. We used to do really crazy stuff to people, but not indicated, and that's actually harmful for our patients anymore, not recommended. So some stats to consider, 26% of our subarach patients are gonna die before they get to the hospital. Another 13% are gonna die while they're in your hospital bed, all right? So it has a high mortality. So understanding a stepwise approach to care of these patients is extremely important. Those who have medical complications are gonna have a worse outcome, kind of common sense, but it's proven. Angiographic presence of vasospasm is also, as a cause of DCI, is a predictor of morbidity, mortality. If our patients have vasospasm, we need to pay attention. It's a predictor that they could die or they're gonna leave with a bigger deficit from your hospital. Of our aneurysmal subarachnoid patients, 30%, this isn't a small number, 30% are gonna develop DCI. Okay, so this is where our therapies today that we're talking about are targeting. Most commonly occurs between days 4 and 14. Mechanisms of DCI is really important. My last slide is talking about future research, but this is where it is important is because what is the mechanism of DCI? We think it's around microthrombosis, disruption of the blood-brain barrier, cortical spreading and depolarization and ischemia of the brain, and cerebral autoregulation disruption and issues. So these are what we think are sort of the pathophysiology behind DCI and what some of our newer trials and therapies are really targeting. Historically though, therapies have really just targeted, let's fix the vasospasm. This has had limited impact on DCI and mortality rates out. I will say historical treatment of vasospasm. I will say most of our therapies still are just targeting that, but we're getting better and we have more interventions that will be coming. But our goal is to monitor, detect, manage through intervention, okay? This is our stepwise approach. This is very small. I actually had this great idea that I was gonna hand everybody out this little algorithm, but there's a lot of you in the room and I'm glad I didn't do that because that would be a lot of trees and printer, paper, copier stuff. So just know that I would encourage everybody to look at this. I think this is a really nice algorithm. Anybody wants my slides are welcome to them. But I do think that this is a nice way to look at how you're gonna walk through having your patient with a subarachnoid hemorrhage, initiating oral nimodipine, starting your neurological exams. Big question at this point in this stepwise approach is, do you have a good neurological exam? It's really important to understand that piece. If you have a good clinical neuro exam to follow, great, follow it, okay? The other diagnostics are gonna be trends. They're gonna be trends that may help you to predict what's gonna happen in the next 7, 10, 12, 14 days, okay? If you start to see alterations in that neuro exam, that's why our handoff as nurses is so critical. Or if we're APPs in the ICU, that's why it's so critical. Because if my exam for my APP last night is looking different than what I'm seeing today, and I see trending TCDs, I better know that I need to be considering that that could be a predictor of what's happening for this patient and then in the coming days. Do I want to intervene now, or are we going to intervene in the next couple of days? So vasospasm and DCI, so the mechanism of secondary injury and monitoring for this is really critical. So we have intermittent tools we can use, and then we have some continuous tools. So your neuro exam, you should be doing this on every aneurysmal subarachnoid hemorrhage, right? Your TCVs. This is in helping vasospasm detection and can be a predictor of DCI. Keeping in mind that TCVs really historically were designed to really look at spasm on middle cerebral arteries. And all of us tend to look at the numbers in our ACAs and our PCAs and everywhere else, and it is good, like, okay, let's trend it. But you always have to keep in mind, what was this tool intended for and what was it really intended to measure? And really it's to look at middle cerebral artery vessels and velocities, but good tool nonetheless, we use it all the time. CTA and CTP, also good for vasospasm detection and DCI prediction, right? When we start to think about our continuous tools, continuous EEG, you should be considering that, not for every aneurysmal subarachnoid patient, but for high grade bleeds, okay? For those high Hunt scores, those high modified Fisher scores, you've got a lot of blood on the head, you've got poor neurological exam on arrival. These are the patients that you should be considering. Should I, and you don't have a good exam to follow, should I put them on continuous EEG out of the gate? It's very reasonable to consider to do it. Your LICOX, your brain tissue monitoring, yes, for your high grade bleeds, absolutely reasonable for DCI detection. And again, keeping in mind brain tissue monitoring, cerebral microdialysis, it's not going to detect vasospasm, but it may help to predict DCI. Okay, that's what those tools are used for. They're very different than, say, your TCVs or your CTAs, right? That actually can detect and look at and actually visualize the vasospasm. So monitoring options, tools to assist identification or prediction are TCVs. As we said, most studies focus on MCAs, defined as the mean cerebral blood flow of greater than velocity of greater than or equal to 120 centimeters a second, and Lingard ratio of greater than or equal to 3. Really, there's been a big meta-analysis that showed when evidence of vasospasm on TCV, it's a very high predictor of DCI, which is why we do them all the time, right? Which is why I would say we should try to be doing TCVs every day. Some do them every other day. It really depends on what organization you're at. CTAs, 91% sensitive in some studies in identifying vasospasm after symptom onset. So they show us pretty clear pictures. You do always have to keep in mind that there's diminished accuracy in the distal vasculature. So if somebody's in spasm in the distal MCAs and some of your distal ACAs, really your CTAs are probably not sensitive enough to pick it up. CTA scores are a direct predictor of DCI and have poor neurological outcomes, okay? So if we see evidence of spasm on CTA, again, we should pay attention. You gotta put all the pieces together. CTPs can be used and are used in some centers as an early predictor of perfusion abnormalities. They have in one study a positive predictor value of 0.67 for DCI. So some centers will do a perfusion scan early on to obtain that baseline and to look at that as a potential predictor of DCI. Continuous EEG, this is becoming more and more feasible, but you have to say, am I a center that can put our patient on continuous EEG? It is a very predictable response to seeing to ischemia on the brain, and really looks at kind of the spectral features of the EEG, looking at those sort of your alpha delta presence of and frequency of your alpha delta theta gamma waves, and looking at kind of those spectral features. Your brain oxygenation, so provides kind of a surrogate measure of your cerebral blood flow, right? Kind of that oxygen, your supply, diffusion, and consumption, looking at what the demand and supply is and looking at that partial pressure of oxygen on the brain. And then your cerebral microdialysis. Do you guys in the room use microdialysis in your ICUs? Okay, so you know, it is one of those tools that it can detect metabolic changes associated with DCI. Lactate pyruvate ratios are an important measure of this. So looking at that ratio, if it's greater than 20, been shown to have poor outcomes and shown to have a very kind of high metabolic crises and state. And is suggestive of potential intervention in ischemia on the brain. And then same thing with glutamate. Those high levels of glutamate have been predictors of poor outcomes and increased morbidity, mortality, and correlate with positive DCI. So considerations when monitoring, so obviously nobody in the room is doing microdialysis, so that shows you kind of, we have to consider what tools do we have in our tool chest. But we have to consider some other things, CTA, CTP, we have to consider our dialoads and renal function on these patients. Neuro's historical for being in the scanners all the time, right? We're always in the scanners, boy, do we love them, we just love to radiate the heck out of our patients. Let's go back to CT. Okay. Nurses are really excited about that. Let's pack them up and, you know, all the tubes and the drains and the lumbar drains that are connected to the Alaris pump and, you know, I mean, this stuff is not easy, but we have to consider all that. And what's the hemodynamic stability of that patient, or can they really go? So while it's a tool, maybe it's not a reasonable tool if they can't move, safely, in a stable way. Continue on TCDs, do you have these 24/7? Who's reading them? I think that's an important question. I find when I go to organizations, different people are reading TCDs. So what's their level of training? Are they ultrasound technologists? Are these neurologists? A lot of APPs are becoming trained in reading TCDs. So understanding the training behind it and is there a variability between your readers? One of the reasons we use TCDs is to trend them. Is the trend reliable, or is there inter-rater reliability in the reads? Something you absolutely have to consider when looking at those trends, and especially if you're going to intervene on it. Sometimes you lose TCDs because you just don't have bone windows. Okay, when you look at microdialysis and Lycox, biggest thing about them is they're invasive. These are not non-invasive procedures, right? Probe location is critical. So again, you have to be understanding and feeling like you have a good location of the catheter placement. Otherwise, your reads could be wrong. And if you're going to trend and intervene, that's an important piece, is understanding that you have very good placement. Now that we rely on our neurosurgeons to be good placement of their catheters. But we have to be really mindful at bedside, as these are, those of you, I'm sure you guys have Lycox and can use those, you know, those probes are they just don't have very stable, they're easy to manipulate, let's just say that, right? They move around a lot, so we have to be very cautious of that. There's a large learning curve in understanding the diagnostic utility of cerebral microdialysis. If you've never used it, understanding what the numbers mean and how you should intervene on them takes some time. And then resource intense. It is very resource intense to do cerebral microdialysis on bedside nursing. There's frequent sampling that's involved with this therapy, and so you have to consider that in your staffing. So once we've monitored for these patients, we've instituted all the right monitoring components. Now, what are we going to do when we see that there's vasospasm? What are the actual interventions? Sometimes maybe there's not vasospasm yet, but what are some of the interventions? Well, nimodipine's one, right? We said out of the gate, it's a class 1 level A intervention that should be done for all aneurysmal patients. Milrinone is something we can consider, conventional angiogram with intervention, and then BP augmentation. So nimodipine is dihydropyridine calcium channel blocker, right? Shown to be beneficial in prevention of DCI and improve functional outcomes. There are a couple studies, Hernandez study, a couple of others out there that show actually that disruption of nimodipine is a predictor of potentially poor outcomes. So, and there's an inverse relationship between disruption of nimodipine and outcomes of DCI. So you have to be mindful that we don't want to disrupt even missing those doses of nimodipine, which all of us have been probably guilty if we've been bedside nurses of doing that at times, saying, oh, my blood pressure's low, I'm just gonna skip this dose, we're gonna hold it, we'll deal with this in a little while. Those missed doses actually are very important because there's some randomized control trials that show that there's an inverse relationship, that when we miss doses, that can lead to potential be a predictor of DCI down the road. Okay, so try to keep those missed doses at a minimum, if at all. Initiate PO dosing early. Remember, we're given 60 Q4. If you have a lot of BP issues, you're going to go 30 Q2 as much as you can. Again, trying not to miss too many doses. Continuous administration is found to be beneficial. But the titration and timing of the initiation of a drip like that is very debatable. But in the United States, intravenous use of nimodipine is not approved. So just say this is used in our European colleagues' hospitals. It is shown to have a great, actually quite a bit of benefit. Maybe we'll get there here in the United States, but not yet FDA approved, so not an option for us, but certainly we want everybody to be aware that it is out there. Milrinone, an inotrope phosphodiesterase inhibitor, potent vasodilator, right? We use it a lot with our congestive heart failure patients. We do see this used both intraarterial and intravenous. Typically intravenous, if it is being given, it's usually given with or without a bolus and a typical dose of 0.5 or 0.75 mics per kilo per minute. Can be continuous up to 2 weeks. It really depends on the provider and sort of how sick that patient is, right? This is something that's indicated once we're really into a DCI state in helping to augment that vasodilatory effect. You should have a standard protocol. If you don't have one and you find that you're going to be an organization that's going to be using milrinone IV on a regular basis, putting together a standard protocol is really important. Again, using this in peak DCI window may have beneficial effects in preventing symptomatic spasm or DCI. Hypotension is very common, right? We're oftentimes going to require a pressor at this point if we're going to be introducing milrinone, and Roland dosing requires some further investigation. There's really no big RCTs on milrinone in the cerebral vasospasm patient population, so this is really work that needs to be done. Blood pressure, so reduced variability in blood pressure is associated with possibly improved outcomes. So what this means is not having all of this up and down, right? So really getting to that steady state where we've really plateaued in a good state of blood pressure control is really important. We don't want that, oh, we're at 100, we're at 110, we're at 140, we're at back down to 90, we're at 140. That is associated with potentially poorer outcomes. So really getting to steady state. It's reasonably to augment blood pressure with pressures if patients are symptomatic with DCI. But you have to know that when we augment blood pressures, there's really not known improved outcomes with it. Okay, it's not linked to having a long-term effect on these patients. In one retrospective study, norepi was preferred over phenyl, showing improved neurological exam of those patients being discharged to home in acute rehab, and that was statistically significant for that patient population. Intravascular volume, we're going to talk about this. Goal is euvolemia, prevention of hypovolemia. We're monitoring, right? Isonos, hemoglobin, fluid status, sodiums, providing IV fluids as needed. And I'm just going to say that when we think about our aneurysmal subarachnoid hemorrhage patients, it's common to see some cerebral salt wasting on them. And so volume replacement is very reasonable. Actually, can I go back there? So cerebral salt wasting, some of our patients, we might see some SAADH syndromes with these patients. I do have DI on here. I actually kept the slide. I gave a different talk and I thought it was just handy to use. But cerebral salt wasting is really what we see most commonly with these patients, right? They become hypovolemic, they're peeing out of the gate, they just won't stop peeing, they're losing all their salt, they're hyponatremic, though not significantly hyponatremic, right? They're like probably riding the 130s or something, their sodiums. So we've got to think about kind of trying to get that back up for them. Their serum osms are down, their urine sodiums are up if you're going to measure that. And they just are losing increased secretion of sodium water, right? Their sodium and water channels are just open. Those sodium channels are open, they're losing it. So we need to think about volume replacement, not aggressively. So we're not talking triple H, but again, we want to keep these patients euvolemic and kind of normal natremic, right? So 0.9 at a regular rate. Fludrocortisone 0.2 IV or PO, almost everybody gives it PO, right? Monitor for pulmonary edema, hypertension, and hypokalemia with these medications. Salt tabs daily can be indicated. Increased salt take through their diet, and hypertonic salines, right? PRN. depending on what your protocol is, are you using 3%, 23%, depends on how much salt they might be wasting. Do not give furosemide. Lasix is not gonna help in this situation, right? You might be giving it for another reason, but it is not gonna help with your cerebral salt wasting patients. So these are just your management of medical complications. Hypovolemia, big exclamation point, let's not do it. Don't go there. Let's keep our patients euvolemic. How do we do that? Oh, let's look at the eyes and O's every day. It's a very simple standard nursing 101 assessment. Eyes and O's every day. I remember when we learned this, when we're out on the units, it's actually really important for these patients. And I will say, I argue all the time with my trauma residents who want to tell me, oh no, we like to keep them dry. And I'm like, that's great. When this is a trauma patient, you can talk about keeping my patient dry. But this is not a trauma patient. And I work in 5 level 1 trauma centers. So a lot of them want to do this if these patients end up in our trauma unit versus our neuro unit. And I have to remind some of them, listen, this is a very different pathway. Guidelines for trauma look very different than our aneurysmal subarachs. These patients need to be euvolemic. I don't need them really wet, but I can't have them dehydrated like this. So it is really important to pay attention to that and understand that looking at eyes and O's every day for these patients is extremely important. Just know that CBP is a poor predictor of fluid status overall. We used to use it a lot. Yes, if you have mechanism for monitoring cardiac output and that and looking at your preload, that is a great predictor. Whatever therapies you want to initiate to maintain euvolemia, great, whether it's fluids, whether it's medications, your mineral corticoids to hold on to that, you should be considering it. I'm spending time talking about this because intravascular volume loss is associated with DCI and prediction of DCI. So this is a really important piece and something we just probably don't pay quite enough attention to. We do look at salt a lot, but I think we don't look at our eyes and nose probably as much as we could. So when we think about medical interventions, let's just say we maxed them out. Our medical interventions are, we've done all we can. We've got their sodium up, their vascular volumes up, we've gotten nimodipine on board, blood pressure is augmented, fluid status is spectacular, but it's not enough. TCDs are trending, maybe their neuro exams changing, so now what? Well, what is your trigger to proceed with more intervention? And this is why I say when you have a protocol in your organization, you do want to know what are your triggers to say, hey, listen, I've got to go talk to my intensivist team, my interventional team to say, is this going to be a patient that is good for an endovascular procedure at this point? So, or maybe really the first place to start is angiographic imaging, right? So do you have a recent CTA? Have we gone to look to see what the blood vessels look like? Do you have trending TCDs? Is that your trigger? Is that when you see your TCDs are up and you've got mild to moderate vasospasm, is that when you're going to pull the trigger to do something more? Medical management's maxed out. Okay, is that enough of a trigger that you're going to go to intervention? Your neurological exam changes. This is probably the most important of all of this, right? If you have a great neuro exam and you're a patient, you've medically maxed them out and your neuro exam is changing, we need to pay attention. If there's no other rationale on that we can say, you know, they weren't just given Ativan or Haldol or something to change their neuro exam on you. If you have no other rationale, a neuro exam change, even if it's subtle, should really be paid attention to. So what are some of our invasive interventions to treat vasospasm? Well, outside of, well, no, that's not even an intervention. Really, what it comes down to is endovascular. We've got to take them to the endovascular lab at that point to get some relief. And some of those options are intraarterial medication. So we need some vasodilators. We can consider some conventional transluminal balloon angioplasty, right? It's been around forever. And then we can talk about a little bit, I'll talk about stent retriever angioplasty, which is something we're seeing a little bit more of. Right, so angiogram with IA meds, vasodilators help both proximal and distal vascular access for treatment, right? So we can get to the very distal vasculature using intraarterial vasodilators. There's a variety of agents that are used. No one is better than another, though usually it's a provider preference. And they tend to use the same one over and over because they feel comfortable with that. Calcium channel blockers are definitely the most common. You do see some of the phosphodiesterase inhibitors like milrinone. We're seeing more of that. Are you guys, I know our endovascular guys, physicians left here, but are you guys doing IA milrinone in your endovascular labs? Some nodding yes? Yeah, okay. So commonly we see milrinone 2 to 15 mg at intra-arterial is what's been reported out there in the literature. Nimodipine, not available in the United States intra-arterial, but can be delivered in other centers. Verapamil, what's reported out there, 15 to 50 milligrams IA. I will say definitely have seen plenty more than that delivered in my organization. If somebody's got really bad spasm, you might deliver more than that. And again, that's based on provider discretion. Old school drug, really don't see it as much anymore, but you see papaverine, that used to be way back in the day. Now some are nodding, right? We used to use a lot of papaverine in the angio lab. We don't see that as much now because we've got better drugs on the market that we can do and have very good vasodilatory effect. What else can we use in the angio lab? Well, we can think about transluminal balloon angioplasty. This is kind of historical, old mechanism by which we can treat vasospasm. Some considerations are balloon size and balloon type, like the compliance of it. Keeping in mind that, extra compliant balloons, they run a risk. You inflate extra compliant balloons, there's some evidence that suggests that there's increased risk of vessel rupture with those extra compliant balloons in the artery. And keeping in mind that it's really contraindicated in really small vessels. So in that distal vasculature, balloons are, you have to be very cautious, and in calcified vessels, right? This runs a risk of vessel rupture and also thromboembolic complications. And those are the downsides to using balloon angioplasty. So a lot of times our endovascular guys are going to go to our intra-arterial medications as a first-line therapy, and will consider balloon angioplasty as a secondary therapy, just because these do come with some potential risk and complications. I will say I used to work at one of my organizations has a really young patient population, and those patients with aneurysmal subarachnoid would go into spasm all the time. And one of the biggest reasons is just because they don't really have these calcified vessels. I work in an organization now that have a ton of octogenarians, and they come in with these aneurysmal subarachnoids and their vessels are all calcified and, thickened, and those vessels don't want to move, they don't do much, and they aren't at higher risk of vasospasm. So we actually don't see as much spasm in some of our organizations with our older patient population. So that's just something for you to, also be paying attention to. What's your patient demographic look like? Who should we be expecting to go into vasospasm more than another? Another type of endovascular treatment, this particular picture here is comes from the VITAL study. This is, and again, I don't have a preference for any devices used that are shown here. The particular VITAL study looked at the NEVA device. And this is showing, the goal of this was to show greater than 50% vessel improvement. So with the use of stent angioplasty. So, and these are stent retrievers that this is particularly indicated or has been found to be approved as a humanitarian use device. And so we can use that as an HDE. That is one device that's available to us now and has been shown to be effective in improved vessel narrowing. Many of these studies that are small studies looking at stent angioplasty, which is newer on the market, uses this in combination with intra-arterial vasodilators. This is a different study. This was the stent relax study using the P-relax stent. This is not available to us in the United States, but used in European markets and organizations. Unique to this is that this is used like a stent retriever, but is not resheathed. And so it's deployed and pulled back out without a lot of arterial shear. So it is nice to see that we are looking at in this space particular devices that will aid us in treating vasospasm, but using retrievers or devices that are going to potentially come to market approved specifically for vasospasm. So I love that this is where the field is headed, and we're seeing more of this because you know, there is some risks associated, and I think with some of the older endovascular guys I meet aren't as in favor of using conventional balloon angioplasty anymore until they have to. So looking at these other types of options, I think is going to be nice, and we'll be seeing more of them. So I'm gonna end, and I have no idea how much time I have, so hopefully I can just get through this case in time. But I'm just gonna show you a case and imaging review and how this is one example of how we pull all of this together. We had a 40-year-old female, young, right? So, okay, off the bat, not thinking calcified vessel, young woman, who presents without any significant history, i.e. never goes to the doctor, and came to our emergency department, found unresponsive at home, by one of her children, has 4 children. She's the primary caregiver of her 4 small children. CT head with diffuse subarach with IVH, CTA head and neck done, showed left SCA aneurysm. She was intubated, EVD placed, we coiled that left SCA aneurysm. She's the one that has 5 modified Fisher 4. Okay, so she is a high-grade bleed, right? She's young, 40 years old, high-grade bleed, she's got IVH. Unresponsive, we have 0 exam, okay? So think about these things that we talked about in the stepwise process of how we're gonna kind of try to monitor for vasospasm. So really quickly, I'm just gonna kind of show you the procedure she went through. So post-bleed day 0, in September, we coiled the aneurysm, day 0. She came back to us bleed, day 6, for her first, vasospasm treatment. Intraarterial injection of 40 milligrams per verapamil. So she got 20 in the verts and 20 in the carotids. 3 days later, she came back to us again in spasm. Intraarterial injection for verapamil 25 milligrams to the left, carotid 25 milligrams to the right. I laugh at this when I see because you can see she came back the very next day again, still in spasm, change in neuroexam, and I'll show you this. We gave 30 and 30 to the carotids and 10 to the vert in the back. She came back to us 4 days later in spasm still, right MCA, left MCA, basilar and verapamil, 30, 10, and 20, you can see, and she had angioplasty of those vessels. So this was a really sick lady. She was in severe vasospasm. And she had multiple procedures. We should not hesitate to bring these patients down as often as they need to come down for this. We don't have another, if we've maxed out medically, we have no other mechanism of treating these patients. And if you don't treat them, they're gonna have profound morbidity, okay, if not death, during that hospital course. So putting it together, so I put on the right, you're right, post-bleed day 2, 4, 6, 8. So I just kind of gave a general idea. We didn't have an exam for about 10 days. We were finally able, and you can see her TCDs were elevated almost immediately on day 3. Her MCAs were not quite, she was in a little mild spasm, 110, 117 on the MCAs. Day later, she was definitely in spasm with those MCAs in the 150s, 170s. You can see we got CTA, she had a hypodensities in the cerebellum on that same time that she was starting to have that mild vasospasm. And we could see she looked like she had bilateral PCA spasm on that CTA on the 12th. This was somebody we started on nimodipine day 0. She continued through her hospital course to day 21. We put her in a Pentogar coma, and she was on the regular stuff with that Pro, Nimbex, Norepi to keep her pressures up. She was getting 3% boluses through that. We coiled her that first day. Then you can see the sequence of events. On the 10th, we had a poor exam. We've finally been able to kind of start to, she had a poor exam on the 10th. Well, I should have put no exam because the Pentogar didn't come off until the 18th. And on the, actually that's wrong. I had meant to change that date. The Pentogar came off on the 13th. And we still didn't have a good exam though. And so, and her TCDs were trending. You can see on the 18th, they were in the 150s, 170s, into the 200s on the 19th. And on the 19th, and 18th was when we took her back for angio for vasospasm. If you recall on the 18th, and I think I have it here, this is what her head CT looked like. So you can see she had pretty significant vasospasm on the CT of the head. This is the diffuse to moderate spasm. Basilar didn't look too bad here as it's coming up, but the MCAs really at the terminus of the carotids looked okay, but a little bit of spasm there on that head and neck study. And then we took her for angio on the 18th, and you can see she had pretty diffuse spasm through those M1, M2 segments there, that ACA. So this is pre-vasodilator before we injected the verapamil. Keeping in mind, I don't know if you recall, but we gave 25 and 25 here. We have a new younger neurointerventionalist that was being very cautious, very cautious. And I was like, that's it? He was like, would you have given more? And I was like, yeah, look at that. That looks terrible. You know, I'm like, but you're the boss, let's do it. Okay, she came back to us on the 19th. So I'll show you that again, but this is pre. So keep in mind, and I have my AP and lateral switch, sorry, for those of you that work in the endovascular lab, that was like, I'm like, why did I do that? But anyways, on your left is the AP. So when you look at that AP, this is pre-injection of the intraarterial verapamil, and then this is post. So you can see those MCAs opened ever so slightly with that little bit of 25 milligrams. He didn't selectively catheterize MCA and give the vasodilator there. Actually, if you recall, he gave it on the carotid. So again, this is important as the technique. You want to inject into the catheter that you want to affect. So we had some effect with that vasodilation, but really not true effect. So bringing that back forward, so you can see the pentobarb was off on the 19th, still on pressors. We took her back again. We gave 70 milligrams that next day of verapamil. So we injected the hell out of those arteries. We got MCAs and the basilar at that point. She continued to have trending TCDs, and by the 22nd, TCDs were in the 350s and 400s. I have to say I've never really seen TCDs that high, and I kept thinking, is this an error? Is this an error? But it really was true. And she was in severe spasm. We ended up bringing her back. She got 60 of verapamil that day, and we angioplasty multiple vessels on the 23rd. Very sick young lady. Good news is she actually survived, and she came back to us for a 6-month follow-up. Saw her in clinic. Her biggest complaint after all of that was gait and balance. She was wearing bilateral AFOs. She graduated from a walker to a cane. She was caring for 4 children with the help of her mother. She wanted to return to work. Her exam was she was very alert and oriented. She was moving all of her extremities strong. Her upper extremities were definitely stronger than her lowers. She was weak distal, and that was just the location of the blood. Her feet, she had very hard difficulties with her plantar and dorsiflexion, which is why she had those AFOs on. She had some mild ataxia and some dysarthria, but was swallowing, eating okay, completing almost all of her own ADLs on her own. This is what her 6-month DSA looked like. Her aneurysm was secured. She had a stable and treated ICA aneurysm, and she had absolutely 0 spasm. So this is that same injection of that left carotid, looked beautiful. And so our team did a really nice job opening up these arteries. What's the nursing impact, right, on prevention and our intervention of delayed brain injury? So taking it back to what I started with. DCI and vasospasm detection is a big part of all of our job, whether we're the APP or we're the nurse at the bedside, managing intravascular volume, just looking at eyes and nose, reminding your APPs, if you're the nurse at the bedside, hey, this patient's 3 liters behind. Did we want to do something about it today? They're an aneurysm patient. You know, we all get busy in our minds in other places. We're a team. And as Dr. Hamill said earlier, it takes a team to really be mindful of making sure all components are addressed. Neuro exam, can't say enough about it, facilitating targeted diagnoses. And this goes to show that really it's class 1, level BNR, neuro exams and detection of neuro exam changes is critical in prevention of secondary complications for these patients and prevention of DCI. Okay, it's proven in our studies. If your exams make a difference on these patients, don't minimize it. So my final slide, knowledge gaps and further research. Where are we going in vasospasm and DCI combination therapies? Well, we do it a lot, but what's the standard? And it's not protocolized. We don't have a lot of great studies or certainly no RCTs that look at combined therapies and what's the best. Use of IA medications and stent retriever, new angioplasty tools. There's a lack of evidence in our RCTs exploring the utility and the outcome of the therapies as a combined measure. Neuroganglia blocks is currently being explored, so how the neuroganglia actually interact with our neurovascular system and blocking the neuroganglia and how that may affect vasospasm and DCI is being explored right now in some small pilot animal studies. Intrathecal medications, very specifically to heme degradation and vasodilators like milrinone, nimodipine. These are done in animal studies, but not yet in human. We don't understand this well in human. And then cisternal lavage with fibrinolytics, like our urokinase, whatever you want to use in spasmolytic medications. Does this affect prevention of DCI and vasospasm if we do cisternal lavage? So all of these things are being explored or due to be explored in this little vasospasm space. And that's all I got for you today. So I hope this was helpful. Thank you.
Does anybody have any questions?
It's real easy. So why the delay on the angioplasty? Just because it was provider choice, like you waited
On that case?
Yeah, because she had gone back so many times, like why not do it?
Yeah, it was, I'm gonna say it was a provider choice. Yes, we had a, and again, I think you see this, it's their comfort level. He was, he's a younger provider, if you will, and an endovascular, interventionalist. He's great, but he just didn't feel comfortable or like it was indicated. And I think he was a little hesitant, obviously, because she had so much distal, spasm that he felt like the dilator would have been appropriate. So the interventionalist that actually gave that high dose of 60 plus multiple angioplasty was one of our older interventionalists that then said, no, I'm kind of going to bring out the big guns and felt a little bit more comfortable doing it. Good question though.
Any other questions?
And that's where like, even, you know, our investor guy, when he came out and he asked me, would you have given more? And I was like, yes. So for those of you that have a lot of experience in the field, talk to your interventionalists, especially if they're, you know, newer and what you've seen, and don't minimize what your experience is in caring for these patients after receiving this kind of therapy. Yeah.
Thank you for the great talk. So my question is, the nimodipine, you said she had not missed any doses. So in your practice, are you augmenting blood pressure with vasopressors when they do not tolerate nimodipine?
Yes, a lot. We don't hesitate to put on vasopressors to be able to support nimodipine administration. So, and again, we're not starting vasopressors if somebody is not in symptomatic vasospasm. And that's really the only time that BP augmentation has been found to be useful, keeping that in mind. It's when somebody has symptomatic vasospasm. You don't want, you know, you want to watch blood pressure, but until that point, you're not going to start pressors. However, if you have to kind of have that discussion of, are they getting so hypotensive that you cannot give nimodipine? Again, most people, I will say, once you break up and go to that 30 Q2, most people do tolerate that. Now, if their pressures are gonna live at 100, you know, if they're gonna have a systolic of 100, but their maps look okay, but they're not symptomatic, that's okay. You don't need to start a pressor. Let them ride it out. It makes some of us feel uncomfortable in that vasospasm window because you're like, oh, I want them all to be 160, you know, I want them all to ride there. But if their blood pressure is sitting fine and they're not symptomatic and they're tolerating their nimodipine, we know that that is helping them in the long term, in terms of impacting outcome. So we don't hesitate to start pressors out if we feel that they are symptomatic. They start to have a weakness, they have a new numbness, tingling, whatever it might be, if they declare themselves and we start pressors, yes. And our first choice is Norepi. Thank you.
Great time. Don't forget your cards, right? So like get the vendors to give you the stickers for your cards and you can register the basket at the end. We're gonna start promptly at 11 o'clock.
11 and 5.
11 o'clock. Okay, so be like, be back.
Be back, please.
We'll see you guys.